Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Nomograms Predicting Progression-Free Survival, Overall Survival, and Pelvic Recurrence in Locally Advanced Cervix Cancer, developed from an analysis of identifiable prognostic factors in patients from NRG Oncology, Gynecologic Oncology Group randomized trials of chemoradiation by Peter G. Rose et al. My name is Kathleen Moore, and I am an Associate Professor of Gynecologic Oncology at the Stevenson, Oklahoma Cancer Center in Oklahoma City, Oklahoma. My oncologic specialty is gynecologic oncology. This issue of the journal contains 2 articles helpful for treatment decision-making for cervix cancer, the 4th most common cancer in women. Rose et al. Evaluated data from over 2,000 women treated for local regionally advanced cervix cancer and developed a nomogram that proposes to stratify women by prognostic risk. Kitagawa et al. Report on a large randomized phase 3 trial comparing standard of care cisplatin and paclitaxel to carboplatin and paclitaxel, seeking to investigate whether the latter, more tolerable regimen, was non-inferior to cisplatin and paclitaxel. In 1999, the National Cancer Institute recommended that treatment for locally advanced cervical cancer, which comprises stage 1B2 through 4A, should include the addition of cisplatin-based chemotherapy to radiation, as demonstrated by 5 randomized controlled trials showing a decrease in the risk of death by 40%. Despite significant improvements with the addition of cisplatin to radiation, local recurrences still hover around a rate of 20%, and 3-year overall survival ranges from 67 to 74%, depending on the study. To further decrease the rate of recurrences, which are almost universally lethal, treatment strategies have included combining another cytotoxic therapy with cisplatin radiation, addition of targeted therapies to cisplatin radiation, neoadjuvant chemotherapy preceding cisplatin radiation, and consolidation cytotoxic therapy following cisplatin radiation. Early trials with patients receiving radiation alone demonstrated that approximately 50% of patients never had recurrences, and for these patients, additional treatment only adds harm. Prognostic algorithms which may guide which patients need additional therapy beyond cisplatin radiation from those whose likelihood of cure is high with cisplatin radiation alone would allow for more targeted evaluation of more aggressive therapies. Rose et al. Presents an analysis of locally advanced cervix cancer patients treated on phase 3 randomized clinical trials of radiation therapy alone versus cisplatin radiation therapy, and nomograms were constructed for 2-year progression-free survival, 5-year overall survival, and pelvic recurrence. These 6 included trials span 26 years from first study launch to last study closure. During this time, protocol-mandated radiation treatment length decreased from 10 to 8 weeks, and all studies mandated 2 or 4-field external beam and assigned dose based on anatomic landmarks, for example, 80 Gray to point A. These techniques are still widely used in certain parts of the world, and the nomograms may be most applicable where current techniques mirror the included studies. In the developed world, where much of the radiation for cervix cancer has transitioned to 3-dimensional conformal therapy, intensity modulated radiation therapy, and volumetric dosing, we wonder if this nomogram is applicable. In contrast to the management of patients with earlier stage disease, Treatment of stage 4B and recurrent cervical cancer is generally non-curative. For such patients, we have progressed over the past 30 years from a model of best supportive care to doublet cytotoxic therapy, now with or without bevacizumab, with concordant improvement in overall survival. Since Gynecologic Oncology Group Study 169 demonstrated the improvement in progression-free survival and response rate with the addition of paclitaxel to cisplatin, 3 randomized controlled trials have investigated the optimal treatment of stage 4B and recurrent cervical cancer and guide our current standard of care therapies. GOG 204, GOG Protocol 240, and most recently, in the article that accompanies this editorial, JCOG 0505, GOG 204 compared cisplatin paclitaxel with 3 other cisplatin-based doublet therapies, demonstrating the lack of superiority of these other platinum doublets compared to cisplatin paclitaxel and establishing cisplatin paclitaxel as a reasonable standard in this disease setting. GOG 240 then explored the benefit of adding bevacizumab as well as the possible benefit of a non-platinum containing doublet, paclitaxel topotecan. Significant improvement in overall survival was found with the addition of bevacizumab to chemotherapy backbone, 17 versus 13.3 months. In this issue, Kitagawa et al. Present the findings of the 3rd randomized controlled trial, JCOG 0505, which compared the use of cisplatin paclitaxel to carboplatin paclitaxel. Carboplatin paclitaxel was found to be non-inferior to cisplatin paclitaxel except in the subgroup of patients who did not have prior cisplatin exposure with radiation. For those patients, cisplatin paclitaxel appeared superior to carboplatin paclitaxel. Based on these results, we now have 3 viable options for this population, including carboplatin paclitaxel, cisplatin paclitaxel, and cisplatin paclitaxel plus bevacizumab. To identify the best treatment for each patient, we must keep in mind the goals of palliation of patient symptoms, quality of life, and when possible, extended survival. Anticipated toxicity given a patient's baseline comorbidities and prior therapies is an important consideration for treatment selection. In general, both cisplatin paclitaxel and carboplatin paclitaxel are felt to be well tolerated, especially with the increased utilization of 3 rather than 24-hour paclitaxel infusions when given with cisplatin and the availability of effective anti-emesis regimens. The risk of treatment-related fistula formation is correlated with prior radiation and location of disease recurrence and should be discussed with patients. In GOG 240 and JCOG 0505, 54% and 38% of all patients were reported to have recurred in a radiated field, and so this is not an uncommon scenario. Addition of bevacizumab to chemotherapy resulted in a gastrointestinal fistula rate of 8.3% as compared to 0.9% in the chemotherapy alone arm in GOG 240. All fistulae were in patients with prior pelvic radiation. If toxicity and other patient-related concerns are considered equal, we are in a position to have to select between doublet and triplet therapy as palliation for patients with stage 4B or recurrent cancer. How do we decide for whom more therapy equals better therapy? While not a predictive nomogram, we do have established prognostic criteria derived from prior studies in this patient population developed by Moore et al. And more recently evaluated by Chawari et al. The Moore criteria were created from a retrospective evaluation of patients with stage 4B and recurrent cervix cancer treated with cisplatin-containing chemotherapy regimens on GOG randomized controlled trials. The 5 factors that were associated with decreased likelihood of tumor response to chemotherapy included Black race, performance status greater than 0, prior cisplatin exposure, disease limited to the pelvis, and first recurrence within 1 year of prior treatment. Patients can then be classified into 3 risk groups. High-risk patients are predicted to have a 13% response rate to treatment with platinum-based chemotherapy, while low-risk patients have a predicted response rate of 51%. These criteria were prospectively validated by Tiwari et al. Among patients in Gynecologic Oncology Group Protocol 240. High-risk patients showed the largest benefit in overall survival, gaining approximately 6 months, with a median overall survival comparison of 6.3 versus 12.1 months without and with bevacizumab respectively, while those in the low-risk group showed less benefit with an overall survival difference of 23 versus 21.8 months with and without bevacizumab. Although it is difficult to exclude some degree of benefit with the addition of bevacizumab to chemotherapy in the low-risk group, these data suggest that the magnitude of benefit might be less compared to patients with higher risk disease. It might be informative to apply the more criteria to the JCOG population and determine its validity in this population of patients as well. If validated, these criteria could be a useful adjunct to selecting treatment regimens with the major limitation of lack of comparative outcomes data for carboplatin Taxol versus cisplatin paclitaxel and bevacizumab. In conclusion, the two papers by Kitagawa et al. And Rose et al. In this issue give us treatment options and tools that help maximize not only the benefit of survival with treatment, but minimization of non-beneficial treatment toxicity through identification of patients most and least likely to benefit. This concludes the podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.